Hi, hello everyone. I am Dr. Alpesh Maru, and today I am going to give you a brief idea about pulmonary edema and ARDS, that is acute respiratory distress syndrome. So, without wasting much time, let's start straight away regarding the definition of edema. So, as you all know, edema is nothing but abnormal increase in the interstitial tissue fluid. So, it is the a very important thing that is abnormal. So abnormal increase in the interstitial fluid within the tissue, that is edema. Now one more term, that is anasarca. It is the clinical term. We can say severe and generalized edema with widespread subcutaneous tissue swelling. So when we call a generalized edema, it is known as anasarca. Now types. First of all, edema can be divided into a localized, generalized, special, pitting and non-pitting. Let's get some idea regarding localized types. So it is either due to inflammatory etiology, or either due to lymphatic, or it is due to either toxic or allergic. Now inflammatory, as you all know, whenever you have any injury or any inflammation, there is localized swelling, and it is due to increased capillary permeability, as it is the event of acute inflammation. Now example of lymphatic edema, one is cystic hygroma. There is lymphatic obstruction, or any tumor like for example, if there is breast carcinoma, then there is dilatation of breast lymphatics, so that is produce purely orange appearance, and again it is edematous changes. Now generalize, there is renal edema or cardiac edema, that is produce generalized edema all over the body. Special edema, that is pulmonary and cerebral. Now we are going to discuss today about this pulmonary edema, and two more clinical terms, that is pitting edema and non-pitting edema. As we all know, pitting edema means if you apply a pressure over edematous portion, you will find pit or depression, that is pitting edema. And non-pitting edema, the examples are myxoedema and elephantiasis. In this case, you will find non-pitting edema. You can see very well in this figure. Once you apply pressure over here, the dependent edematous part, you will find such kind of depression, or we can say pit. So that is about pitting edema. So these are the types. Now move towards a difference between, very important short note. Let's get some idea regarding questions from this topic. You will have some short note like difference between transudate and exudate. One more thing, discuss a detailed pathophysiology of pulmonary edema, or we can say etiopathogenesis of pulmonary edema. And third most important question, that is DAD, also known as diffuse alveolar damage, or we can say ARDS. So three very important questions. So first, this difference, transudate versus exudate. So you can see, once you see this slide, as we have already discussed these things in practical classes, exudative means there is association with inflammation, so it is inflammatory edema. And here, but obvious thing is endothelial permeability breach, so there is increase in the endothelial permeability due to inflammation. These two word is important in exudative, and in case of transudative, it is clearly said that it is of cardiac origin or renal origin. So any cardiac pathology or renal pathology without inflammation, so there is no change in the endothelial permeability, so that is about transudate. Now regarding some content, so first of all, protein, is there is leaking of permeability, high protein, at the same time there is high specific gravity, and the same time uh, there is bacterial proliferation, it is inflammatory in case of exudate, so there is plasma glucose level get decrease, and here the glucose will remain same as the plasma glucose in case of transudate. And now regarding pH, it is less than 0.7.3 in case of exudate, and about LDH, it is high in case of exudate, and particularly this ratio, this is again very important, it is greater than zero point 0.6 in case of exudate, and it is less than zero point 0.6 in case of transudate. And as far as cells are concerned, most of the inflammatory cells are seen in exudate. In case of transudate, few cells, particularly mesothelial cells. So this is the difference between transudate and exudate. Now pulmonary edema. Usually lung is free from edema because this plasma oncotic pressure is adequate to prevent escape of fluid. But certain causes are there, and again a classification and causes. Causes are classified in such a way that you can understand the pathophysiology of pulmonary edema. So first of all, hemodynamic edema. So these are the main cause. It is increased hydrostatic pressure. As you all know, there are main mechanism you have already learned in physiology: increase hydrostatic pressure, decrease colloidal oncotic pressure, lymphatic obstruction, sodium water retentions, and some tissue factors. These are the main pathophysiology of edema. We have already seen this thing in our general pathology lecture. So first and foremost etiology, we can say most common cause for hemodynamic edema, pulmonary edema, that is increased hydrostatic pressure because of left-sided heart failure. I will show and I will explain all the things in the next slide. Second cause, that is decreased colloidal oncotic pressure, and the most important symptom, that is nephrotic syndrome. As you all know, nephrotic syndrome is characterized by severe, or we can say massive, albuminuria, hypoalbuminemia, hyperlipidemia, as well as lipiduria. So one characteristic finding, that is hypoalbuminuria, is there is decreased plasma albumin, decrease colloidal oncotic pressure, and lead to edema. So second most important etiology for pulmonary edema is this nephrotic syndrome, or we can say hypoalbuminemia. And the same thing in liver disease, most of the plasma proteins or clotting factors and all the things get sensitized from liver. So whenever there is liver pathology, but obvious there is decreased synthesis of albumin, and thus in turn lead to hypoalbuminemia and decreased colloidal oncotic pressure. Third rare cause, that is lymphatic obstruction, that will lead to pulmonary edema. Now we explain about how left-sided heart failure produce pulmonary edema. You can see in this figure, this is right atrium, right ventricle, left atrium, left ventricle. Most of the blood from upper limb through superior cava drain into right atrium. Most of the blood from lower limbs and extremities through infravena cava reaches into right atrium. Now most of the blood, these are deoxygenated blood, reaches in the right atrium. Now from right atrium through this valve, that is known as tricuspid valve, blood reaches to right ventricle. Now from this right ventricle, blood reaches to the lung through one structure, that is pulmonary artery. And now through pulmonary artery, here you have pulmonary valve. So the pulmonary artery blood reaches to the lung. Now here there is oxygenation taken place. These are the alveoli where gaseous exchanges occur, and through these microcapillaries they produce oxygenation of blood, and again they join into pulmonary vein, and through pulmonary vein this oxygenated blood reaches into left atrium. Now from the left atrium, blood goes to the left ventricle through this valve, that is mitral valve, and again from left ventricle through aorta, all over the body or systemic circulation get this oxygenated blood. So this is the normal cardiac circulation. So whenever there is deficiency or defect in either this mitral valve or the aortic valve or any pathology, that will produce left-sided heart failure. First of all, what is stenosis? That is failure to open the valve. So valve becomes stenosed, closed. So that is one reason. Some other reasons are also there, we will see in a cardiovascular system. But whenever there is defect in this left-sided heart, or we can say any valvular abnormality, thus blood can't go outside from left ventricle to aorta. So blood accumulate in the left ventricle, so thus in turn they have left ventricular hypertrophy. Now there is backflow, blood reaches to left atrium from left ventricle. If there is mitral stenosis, blood can't reach into left ventricle, but most of the blood from left atrium again goes to the pulmonary vein, and back pressure they reach the lung. So lung become more voluminous and edematous. So this is the pathophysiology how left-sided heart failure produce pulmonary edema. I hope you all get understood this mechanism very well. Now second cause, that is edema due to microvascular injury, commonly infection, particularly pneumonia, inhaled gases, liquid aspiration, and second most common cause, that is gastric content. So gastric aspiration produce pulmonary edema. Certain drugs like bleomycin, amphotericin B, certain heroin like drugs, they produce pulmonary edema, and some miscellaneous cause like shock, trauma, and radiation and transfusion related things, and that will produce microvascular injury, and thus in turn leads to edema. And some miscellaneous cause like high altitude and neurogenic pathology. So these are produce again pulmonary edema. So these are the classification or causes of pulmonary edema. Now move toward the pathological changes. As we all know, fluid accumulate in this basal region of the lung, as it is the dependent portion. Now important X-ray finding for MCQ, that is Cullis line. It is nothing but a linear line perpendicular to pleura. So it is because of dilated lymphatics in thickened interlobular septa seen as these kind of linear lines to the pleura, and it is known as Cullis line. Very important MCQ point. Grossly lung become moist and heavy as there is fluid get accumulated. So mixture of air and fluid, you can see Boolean blebs on the external surface. Microscopically most important thing or constant finding of any edema, that is eosinophilic, granular, and pink fluid. So in edema, but obvious, these alveoli become widened and dilated, and there is accumulation of fluid. Now this fluid looks like eosinophilic granular pink on histology. So if you have renal edema, if you have any cardiac edema, you will see same pathological picture. So here in lung edema, you will find alveoli studded with such kind of pinkish eosinophilic fluid, which is admixed with RBC and macrophage. So you can see this is the gross picture. I can zoom it out. See, these are the hyperemic surface. You can show normal lung tissue with reddish changes. This is blebs and bulli. Now these are the edematous fluid. You can see on all these alveoli studded with granular eosinophilic fluid, that is pulmonary edema. So that's all about gross and microscopic feature of edema, that is pulmonary edema. So this is end of our first topic, that is pulmonary edema. Now we move towards very important topic, that is DAD, diffuse alveolar damage, or it is also known as non-cardiogenic pulmonary edema. So far we have seen pulmonary edema due to most common cause, that is left-sided heart failure. That's why it is known as cardiogenic edema. But whenever there is non-cardiac cardiogenic edema, means there is no cardiac pathology, still there is edema. And this is not only edema, but it is edema with some uh, pathology that taken place within the lung alveolar tissue, like hyaline membrane formation, decreased lung compliance, stiff boggy kind of lung formation, atelectasis at the end stage. Such kind of changes taken place, that is known as diffuse alveolar damage, or we can say ARDS. So what is ARDS? It is quite uh, confusing term because it is used for many infections. And recently we have seen this COVID-19 infection. It is turned out to be ARDS at the last stage. We will see it later on. So first of all, we have to understand two terminology. One is ALI and second is ARDS. So what is ALI? Acute lung injury means it is characterized by abrupt onset of significant hypoxemia and pulmonary infiltrate in the absence of cardiac failure. So I already told you there is no cardiac pathology, but still there is edema. Not only edema, but it is associated with hypoxemia. So decreased fraction of inhaled oxygen, as well as you will find pulmonary infiltrate on the chest X-ray, and it has abrupt onset. This is very important word. It is acute, we can say. uh, Textbook says it is having 7 days interval, but usually they are present within 24 hours. So it is acute lung injury. And the same way ARDS is nothing but it is the ALI. Both have inflammation, and that is the main etiology, and that will lead to increased vascular permeability as well as epithelial and endothelial cell death. Now what is the difference? We will see later on. Collectively termed as DAD. Both ALI and ARDS collectively known as diffuse alveolar damage. And whenever there is no inflammation, so no sepsis, still there is any lung edematitis pathology, it is known as acute interstitial pneumonia. Now, what is the difference between ALI and ARDS? See, 3 points are quite common in both the condition. One is acute onset, in ARDS again acute onset. On chest X-ray, you will find bilateral infiltrate in both the condition. And pulmonary arterial wedge pressure, we can say it is pulmonary capillary wedge pressure, or we can say it is left atrial pressure. It is always less than 18 in both the conditions. Now you should remember, now you should understand what is this pulmonary capillary wedge pressure. It is definitely increase in case of left-sided heart failure. So if it is cardiogenic edema, it is always greater than 18, and if it is non-cardiogenic edema, it is less than 18. So it is again common, but important differentiating point, that is the ratio between arterial oxygen to inhaled oxygen, that is less than 300 in case of ALI, and even more severe, it is less than 200 in case of ARDS. That you have to remember. This is the definition given by American UN European concessions. Now definition. It is acute onset. It has bilateral infiltrates. No evidence of left-sided heart failure. So pulmonary capillary blood pressure, it is less than or equal to 18. So no left atrial pressure. Now three things are common. The only difference is this: the ratio less than 300 ALI and less than 200 in case of ARDS. Now what is this ratio that we have to understand thoroughly? See, normally PaO2, that is 95 to 102, we can roughly say it is 100. See, PaO2 means this is the capillary pulmonary artery, or we can say once they got oxygenation, they have 100% oxygen saturation. This is the normal condition. This is the lung, and these are the alveoli where gaseous exchange taken place. And what is FiO2? That is fraction of inhaled oxygen. Usually atmosphere have 21% oxygen, so we can say it is out of 100. So FiO2, that is 0.21, we can roughly say it is 0.20. So normally the ratio is 100 divided by 0.20, it is almost greater than or equal to 500. This is the normal thing. But whenever there is acute lung injury, this alveoli become atelectatic, so there is no gaseous exchange taken place. That is the one thing. So this PaO2, the concentration of this PaO2 get decreased. So we can say oxygen saturation. If it is less than or equal to 6C, then FiO2 remain constant 0.20. The ratio is less than 300. If more severe condition, at the late stage, totally stiff lung, no compliance, and no gaseous exchange taken place, or very partial gaseous exchange taken place, though this PaO2 drop to 40. So in that case, the ratio will be less than or equal to 200, and that is ARDS. So this is how you can differentiate PA, this ratio less than 300, acute lung injury less than 200, ARDS. Now the recent study in 2020, this is published in February 17. This article says pathological finding of COVID-19 is now associated with ARDS. Now it is very commonly we have seen this kind of things in literature. This corona infection have ultimately lead to ARDS. One more study, they have seen this taken place in Wuhan. Out of 191 cases, 54 undergo death, and out of 54, 50 cases, you can see, out of 54, 50 cases, roughly 93% cases who died due to COVID-19 have ARDS, have developed ARDS. So ARDS is very important pathological term that you have to remember. So today by end of this lecture, you will not only learn about ARDS, but you will know about how COVID-19 produce damage to our lung. So risk factor, most important thing, that is pneumonia. As we all know, any infection, any sepsis, that is second most common cause, and third most common cause, that is aspiration. You have to remember this chronology: pneumonia, sepsis, and aspiration. Aspiration of any gastric content or anything else, they will produce ARDS. Apart from this infection, there are certain etiologies are also there, like severe trauma, multiple fracture, pulmonary contusion. These three are associated with trauma. Multiple blood transfusion, even burns, that will produce ARDS. Some drug overdose, after bone marrow transplantation, pulmonary embolism, inhalational injury, and drowning. These are very rare causes, but they are the risk factor for pulmonary ARDS. So you can see pneumonia at the top in 35%, sepsis 26%, aspiration 50%, and rest of the causes are rest 24%. So now, how infection? These are the conditions associated with ARDS, like sepsis. Pulmonary infection not only due to bacterial pneumonia, it is either due to viral pneumonia, as we have COVID-19, some mycoplasma or pneumocystic carrying pneumonia, even tuberculosis. So these are the causes or etiology of infections. Physical injury in the term of trauma, head injury, pulmonary contusion, neo drowning, fracture, burns, and ionizing radiation. These are the physical injury that will produce pulmonary edema. Some oxygen toxicity, so inhaled irritant, smoking on irritant gases and chemicals, that will produce pulmonary ARDS. And now chemical injury like heroin, methadone overdose, overdose of acetyl salicylate acid, that is your PCM, and barbiturate overdose. These all things produce acute respiratory distress syndrome. Some hematological conditions like multiple blood transfusion, as we have already discussed, DIC, again produce ARDS, and very rare cause, these are pancreatitis, uremia, cardiopulmonary bypass, and hypersensitivity reaction. So these are the things that is associated with ARDS. Now pathogenesis. And now in ARDS, this is the main part. Once you understand this pathogenesis, it is very easy for you to write ARDS short note thoroughly, because risk factors, etiology are quite common with edema and all the things. But important thing is pathogenesis, how ARDS take place, and you have to draw one figure that is given in your Robbins, that I will see in later on. So two separate barriers are there. One is microvascular endothelium, and second is alveolar epithelium. So usually gaseous exchange occur between alveolar epithelium and a blood capillary, and this surface known as ACM, alveolar capillary membrane. So whenever there is a defect in this membrane integrity, and this in turn lead to certain event of pathology, like there is necrosis in the type 1 type 2 pneumocyte, there is slough of the alveolar epithelial cells, edematous fluid get accumulated, and then lastly there is hyaline membrane formation. So these are the sequence of events that taken place in ARDS. So we will see one by one. Marker of capillary endothelial injury, that is endothelin and von Willebrand factor. And markers of alveolar epithelial injury, it is the swelling, vacuolization, bleb, and lastly necrosis. So what happens whenever there is damage to alveolar capillary membrane? But obvious, increased vascular permeability, alveolar flooding, more and more fluids get accumulated, loss of diffusion capacity, and there is widespread surfactant abnormality in the form of damage to type 2 pneumocytes. As we all know, the type 2 pneumocyte produce surfactant. Now let's see this figure. This portion, this is a normal portion, right? Normal bronchial epithelium type 1 pneumocyte, that is cover 95% of the alveoli, and this is type 2 pneumocytes, and then this is alveolar macrophage. This is the normal thing. Now whenever there is breach in this alveolar capillary membrane gradient, whenever there is breach, this circulating neutrophil uh, undergo some activation by certain cytokines secreted by macrophage, that is TNF, interleukin 1, and interleukin 8. So by this secretion, this neutrophil get activated, and that is again secret platelet activating factor, certain leukotrienes, and protease is like enzymes. So once these neutrophils get activated, they will produce lots of defect like slough bronchial epithelium. So there is damage to bronchial epithelium, necrosis of type 1 pneumocytes as well as damage to type 2 pneumocytes. So there is straight away deficiency of surfactant. At the same time, there is leaking in the capillary permeability, so cellular debris and edematous fluid is accumulated. And you can see this is hyaline membrane. This is the characteristic or constant finding of ARDS, this hyaline membrane. So these are the changes taken place. Again, I repeat, these circulatory neutrophils activated by these alveolar macrophages by induction of certain cytokines, and in turn activated neutrophil release leukotrienes, protease and platelet activating factor. Due to constant leakage and damage, there is edematous fluid accumulation, damage to bronchial epithelium, pneumocyte, damage to type 1 type 2 both pneumocytes, deficiency of surfactant, and there is one typical hyaline membrane formation. Hyaline membrane is nothing but it is the edematous fluid and debris of these bronchial epithelial cells, and there is typical hyaline membrane formation. So now you can see this is normal portion, this is abnormal portion. So now this lung can't produce proper ventilation, so there is definitely vacuum mismatch. This lung, these alveoli can't expand properly, so there is definitely atelectatic like changes. So this is the damage alveoli, and this damage is quite diffuse, that's why it is known as diffuse alveolar damage. One more thing, that is MIF, that is macrophage inhibitory factor. They is constantly stimulating neutrophil and sustain ongoing process in the form of releasing some fibroblast like factors and produce fibrosis that in the late stage. So these are the same things I have mentioned over here. Two important thing is surfactant inactivation and hyaline membrane formation. So these are the two characteristic finding in case of ARDS. This is about macrophage migratory inhibitory factor. They sustain ongoing process and release certain fibrogenic cytokines like TGF beta and PDGF. So again I repeat, first thing that is activation of these alveolar macrophage and they release certain interleukins and cytokines. Second thing, activated neutrophils and that will produce leukotrienes, PAF and protease. And third thing, that is inactivation of surfactant. There is cellular debris produce protein rich edematous fluid and typical hyaline membrane. You can see in this interstitial space edematous fluid. So now in summarized portion we can say there is edema, not only edema but there is damage to alveolar epithelium, damage to type 1 pneumocyte, damage to type 2 pneumocyte, and the same time there is formation of hyaline membrane. So very important and a very useful pathophysiological events that taken place in ARDS. Not only in ARDS but the same pathophysiology happen in case of COVID-19 infection. So this is how alveoli become stiff and we can say boggy alveoli. So again summarize lung injury. It is in the form of damage to alveolar cells, decreased surfactant production, so decreased lung compliance, atelectasis, uh, release of vasoactive substance, produce bronchoconstriction. In the same time, there is impairment in gas exchange, hyaline membrane formation, decreased lung compliance, impairment in the gaseous exchange. Other way, there is vascular narrowing, obstruction. Again, there is impairment in gaseous exchange. So all the things either in the form of edema or any hyaline membrane formation occur, they will lead to decreased lung compliance, impairment in gaseous exchange, lead to ARDS, that is acute respiratory distress syndrome. So first etiology, that is infection, result into ARDS. Some book mention it has three phase. Exudative phase lasts for 0 to 7 days, proliferative phase 7 to 21 days, and fibrotic phase we can say the recovery phase or end phase lasting more than 3 weeks. This is exudative phase. You can see these are the edematous fluid all over the, this is the electron microscopic image. So these are the edematous fluid. Now there is proliferation of type 2 pneumocytes over here, so it is second phase. Again this is the electron microscopic image, and lastly there is fibrosis. Now you can see tremendous proliferation of fibroblasts. This is the resolving stage. So these are the three stages of ARDS. Now, pathophysiology, how ARDS affect our normal lung physiology. So three very important consequences that taken place in ARDS. One is impairment of gaseous exchange, second is decreased compliance of the lung, and third is increased pulmonary arterial pressure. First, we understand how these gaseous exchange get impaired. As we all know, it is characterized by VQ mismatch. Now we have to understand what is VQ mismatch and what is this dead space, and it is get increase in case of ARDS. So you can see this is the imaginary figure. These are the right ventricle through pulmonary artery. This deoxygenated blood. Now this artery through various microcapillary, through lung, through alveoli, they join to form pulmonary vein, and now this oxygenated blood straight away goes towards the left side of the heart. Now this alveoli, atmospheric oxygen, like they enter the alveoli and they reach up to this distal alveoli. Now at this place, at this interface particular, gaseous exchange taking place. So this deoxygenated blood become oxygenated at this interface and they reach to left side of the heart. Now what happen? Whenever there is ARDS, these alveoli become smaller, very smaller, or we can say atelectatic lung. So now oxygen is not entering through these alveoli, so no gaseous exchange occur in this place. Some alveoli may be normal, so at that place there is gaseous exchange occur, but at some time whenever there is atelectasis due to severe ARDS, no gaseous exchange taking place. So here perfusion remain normal, but this ventilation diminishes. That's why it is known as VQ mismatch, ventilation perfusion mismatch. At the same time, this blood become deoxygenated, or we can say not purely oxygenated. So here there is hypoxemia. At the same time, you will find cyanosis like symptoms. So lung become more and more grasping. This kind of patient undergo grasping, we can say they need more and more oxygen, so they may undergo tachypnea, dyspnea, and very important thing is hypoxemia. So this is how this VQ mismatch occur. And in the same time, this interstitial space, dead space become increase as there is no lung compliance maintained due to deficiency of surfactant. So this is how we can explain VQ mismatch. Same way, we can say most of these alveoli, they produce oxygen. So they this blood get oxygenated at this interface, and CO2 from this arterial blood undergo these alveoli, and that is get expired. This is the normal thing. So whenever there is edematous fluid in between, in case of ARDS, usually oxygen is not that much soluble to water as compared to CO2. It is relatively insoluble in the water. So less number of oxygen get admixed with the this fluid. So again, this pulmonary artery or pulmonary capillary having less oxygen saturation, so decrease PaO2, that is the oxygen saturation in the artery, and again less or decrease PaCO2. This is the first step of, or we can say first degree respiratory failure, so taken place in case of ARDS. Second thing, again decreased compliance due to deficiency of surfactant, lung becomes stiffy boggy. Again MCQ, where lung becomes stiffy and boggy, the condition is ARDS, hallmark of ARDS. Now regarding pulmonary arterial pressure, it is increase up to 25% in case of ARDS. So it is seen in 25% of the patient, sorry, that is increased pulmonary arterial pressure. One more study, that is the molecular pathology in emerging coronavirus infection. So we can say how coronavirus infection emerge and produce ARDS. It is study that seen in 2015 journal, that is Journal of Pathology, and they have published very well narrated article suggest how coronavirus produce ARDS. Now you can see in this figure, COVID infection caused discrimination of pneumocytes in humans and mice and contributing to alveolar dysfunction, edema and hemorrhage. In the same way, in ARDS patient, uncontrolled inflammation and developing fibrosis severely damage gaseous exchange. So you can straight away go through this article and read there is a correlation between ARDS and COVID-19. Now regarding gross picture, his lung become boggy, so it is heavy, firm and reddish. And microscopically, again the very important thing is hyaline membrane. Hyaline membrane is nothing but it is the inflammatory edematous fluid admixed with fibrin and some protein. So that is hyaline membrane. So edematous fluid admixed with protein and necrotic debris of epithelial cells. In the later stage, organized stage, there is type 2 pneumocyte proliferation as well as granulous tissue formation. Now histologically, microscopically, how this ARDS looks like. So you can see in this right side of figure that is quite normal alveoli. You can say it is this much thick with this much thinned out. So you can definitely appreciate this endothelial alveolar lining. Now here you can see this much thickness, and here these are the hyaline membrane. This pinkish structure you can see these are the hyaline membrane. So increase the thickness of alveolar interface. So now this is the constant finding on histology. One more figure, again this is normal and you can see the thickness of this membrane. It is due to edematous fluid as well as this kind of hyaline membrane formation. One more figure, in the lag phase you can see these two arrowhead, this much thickness. So this is a severe case of ARDS. You will find such kind of hyaline membrane formation on histology. The same figure, edema, inflammation and hyaline membrane. So these are the constant finding in case of ARDS. So in summary, you can see again it is molecular pathology of coronavirus infection, normal lung tissue, and now in the damaged condition you will find such kind of hyaline membrane with edema and all these necrotic debris. So this is about a tissue damage in case of coronavirus infection. Same way, the same figure, edema with thickened membrane. Now clinical course. As we have discussed earlier, it is characterized by dyspnea, tachypnea, cyanosis, hypoxemia, and thus in turn lead to respiratory acidosis and failure. Now important MCQ is white out lung. This is very common finding on X-ray, diffuse bilateral infiltrate on radiogram. And very important MCQ, white out of lung. You can see this is the normal X-ray. This blackish portion of this normal lung. This is heart shadow. Now you can see most of the lung in case of ARDS there is whitening. We can say bilateral chest infiltration. So this is typical X-ray finding of ARDS, white out lung. You can see in this figure also. Here white out lung is but obviously identified. One more finding, that is on other planes we can see this kind of damage alveoli filled with such edematous fluid and there is no gaseous exchange taken place, and this is normal alveoli. So you can differentiate how ARDS produce damage to lung alveoli. So in summary, it is ARDS characterized by tachypnea, dyspnea, hypoxia, and there is decreased partial oxygen pressure in the artery and dyspnea. That is the ABG. The important treatment is ventilatory support. So according to Berlin definition, now this is again clinical part. According to Berlin definition, ARDS is defined by first is timing, second is chest imaging, third is origin, and last fourth portion that is oxygenation, that is fraction or we can say ratio within 1 week. That is the acute condition. Chest imaging, as we already discussed, it is characterized by bilateral opacity. Origin, it is not fully explained by cardiac failure, so devoid of cardiac pathology. And third thing, that is this ratio. If it is in a mild condition, it is less than 300, moderate 200, and it is very less say for example less than 100, it is the severe case of ARDS. Now management. It is the last portion. We have to treat underlying cause. Go for tidal volume ventilation and PEP, that is positive and expiratory pressure. We have to given a few volume of air within these atelectatic alveoli, just like we inflate balloon. So we have to expand our alveoli of the lung. The same way we have to monitor airway pressure, go for conservative management, and try to prevent complication as much as possible. So oxygen and mechanical ventilation, but important thing here is position of the patient. Try to maintain position into patient into prone position, because they will uh, reduce pleural pressure, and this is such thus how it helps to reduce edema like symptoms. So this is about management. You can see the prone positioner. This is how patient undergo prone position in the last stage of in the severe case of ARDS. So that's all about ARDS and pulmonary edema. I hope you understand the topic very well. If you have any query, kindly message me. Thank you very much.